Ready? Oh, sure.
Sorry, my case presentation is on still falling for you. So this is what's supposed to have been that in that order is a missed thing. So the history of my patient is I'm presenting a 19-year-old student who's doing an inter second year from Kadapa. He had presented to us with a fever for 9 days and a dry cough for 6 days and throat pain and difficulty in swallowing for 6 days. Now, the history of the presenting company was a fever was a high-grade fever with intermittent chills but no rigors, but almost twice a day over the last 3 days, like a bike in picture, requiring around round-the-clock paracetamols. He also had a dry cough, which was non-productive. So fever, dry cough, which was non-productive cough, intermittent, no positional diurnal variation with no wheeze or hemoptysis. And he also had throat pain with difficulty in swallowing. So he was resorting to soft or liquid diet for the last 3 days with no significant voice change. There was also associated fatigue and generalized myalgia with decreased appetite, but there's no skin rash or arthralgia was noted initially. There was no history of other system involvement, no recent travel history, no exposure to pets or other animal or insect bites preceding the illness. No history of substance use or exogenous steroid use. There's no similar illness in the family members. There's no history of painful swelling of joints with restricted mobility, skin or oral ulcers or dryness of mouth or eyes, or history such of Raynaud's phenomenon, such of autoimmune picture. There's no history such of autoimmune disorders in the family either. The past history, however, though, he was admitted from 25th to 30th of 8, 2012 for a probable rickettsial infection. All these admissions were in CMC. This time he had a 1:160 titer, wheel Felix positive, and was treated with a course of chloramphenicol and doxycycline, and he became better and was discharged. But 4 months later, he had presented with urticarial rash and a fever. And this time there was extensive workup done with including a bone marrow and all of which was negative. The infective workup was also negative, and he was diagnosed with a systemic JA then and was discharged, was treated with naproxen, and he became better. And since then, he was not on follow, but he reports that he had not had any symptoms at home. He was doing well. He was finally admitted for a diagnosed Vivax malaria with a smear showing gametocytes and schizons, and was treated completely and discharged in 2020. Just prior to our illness, he did not have any complaints. He was studying in a college. He just in school, and he had just come for a Dasara holidays, and for the 9 days, he's been having fever, as described earlier. So general examination, he was febrile, 102 Fahrenheit presentation with a tachycardia of 118 per minute with a blood pressure of 90 to 60 millimeters of mercury. Respiratory rate was 20 and saturation was 98% room air. No respiratory distress at this point. There's no pallid icterus sinuses clubbing, generalized lymphadenopathy or edema or JVP. Hydration is very severely dehydrated at presentation though. Oral cavity examination showed a congested posterior pharyngeal wall, slightly enlarged congested tonsils. However, there is no pus point noted in the tonsils. There was no painful cervical adenopathy noted. There was free tongue movement. There was no local tenderness on examination in the throat area also. Oral candidiasis was noted though. Systemic examination, the cardio. All the system examination was within limits. We specifically look for any findings, including the musculoskeletal system examination. There was no tender swollen joints. There was no in the integumentary system also. We did not find any nodules or skin rash. So summarizing, a 19-year-old student with no comorbidities but past history of SGA, systemic juvenile idiopathic arthritis, he presented complaints of severe throat pain and odonophagia with fever, and on examination was found a oral candidiasis with other system examination being within limits. So differentials at this point was based on the temporality and the clinical features. We consider acute pharyngitis with a secondary bacterial infection likely, which is prolonging the course and is not being adequately treated, so it's persisting, or that there is a complication that's developed because the patient had a severe dysphagia or dinophagia and is not able to swallow. He was frankly spitting all the saliva in the ward post admission for the first 2 days. So we're thinking, is there a dysphagia? Is there a severe abscess, paratonsillar, retropharyngeal? Was the other thought process. And because he had a candidal oral candidiasis, the other thought process was, is there a pharyngeal, laryngeal, or esophageal candidiasis, which is the other problem. Or that the whole thing is apart from the actual problem, which is an AUFA with a sick because of the region that is coming from. Is it malaria, the Kadapa, Chittur area? Malaria, scrub typhus was also considered, and typhoid was also considered. Then, of course, autoimmune disorder was also considered. It was in one of our top differentials, but because of the throat pain, we consider all these other things because of the history of SGIA. Adult onset still disease was considered. So seropositive status also considered because of this unexplained oral candidiasis, because there was no history of RAD requiring inhalers, or there is no history of oral steroid use either. Lymphoproliferative disorders are also kept in the mind at the last, though, because at the end of the day, without there was no infective etiology. In case we didn't find any etiology, then persistent fevers with our thought process was a probable lymphoproliferative disorder. So investigations we did was the initial blood showed a leukocytosis 20,400 with neutrophilia of 84% neutrophils, and we had a slight AST elevation, otherwise insignificant, and renal parameters were normal, and we had a in the initial urine donation showed a microscopic hematuria with 54 RBCs. However, we kept this on for and it's protein and hematuria and a proteinuria. So we will come to that later. This ECG was just showing a sinus tachycardia initially with slight right axis, but otherwise within limits. The chest X-ray done initially also showed was fairly within limits, except for the mild prominence of the right descending pulmonary artery. So we continued the further workup for the AUFA. The BBVS was negative. The 3 smears of malarial looking for malarial parasites were also negative. Scrub typhus was negative. All 3 blood cultures were negative. So this is so on 18th we had admit he had present was on 16th in casualty for the above complaints, and he was evaluated. He was given oral antibiotics and discharged for an acute pharyngitis/tonsillitis. On 18th he had come back to again with the same complaints with worsening with persisting fevers, and we had admitted him on that day. So this was a X-ray taken on 18th, and the subsequent X-ray on 21st. So 2.5 days he was being evaluated in the ward for the as mentioned above. On 21st he developed breathlessness, and clinically we found there was an effusion bilaterally. There's decreased air entry. There's no crepit. There was decreased air entry. There's no muffling of heart sounds though, but we did an X-ray and we found that there was we did a bedside ultrasound and we did a there was a effusion left more than right, and we tapped it, and the X-ray also showed the similar findings with the pericardial effusion also. So at this point, we also did an ultrasound and echo. We had booked earlier. This had come that day because our last differential was also infective endocarditis because there's persistent fever, which is unexplained. So all of this ruled out all the things. There's no intra-abdominal collections. There was no infective endocarditis features either. So the urine routine evaluation showed a phase contrast being with normal limits. So there was not catheterized either. So at this point, we just thought we will wait on this and we will see. But proteinuria was still definitely there, 0.59. Okay, so at this point, we were all of infective workup was complete, which is all negative. We had persistent fevers in the ward. He had almost 103 to 104 fevers every 6 hours, requiring 6-hourly paracetamol tablet injections, and without any evidence of infection. And so we had sent this inflammatory workup, considering since stills was on our list next. The CRP was high and the ferritin was also high. And we also did an autoimmune workup just to rule out ANA and C3C4, just to rule out a SLE, which was also negative. The TAP of the pleural analysis at this point was it showed a pH of 7.19 with a protein of 3.3, the LDH of 1185. The total protein here was 5.6, and the LDH was 1185 with the total counts of 38,400 and neutrophilic predominance. So at this point, the consideration was: is it a parapneumonic effusion, or is it a, because when we read about it, we did find that the Still's disease also has a initially can have a neutrophilic predominant effusion, pleural effusion. So we were still leaning on the stills, but we continued on meropenem because at this point he had become more tachypneic, and the X-ray had showed an increase in the effusion. And the pH was also below the norm, like 7.19, so a little bit more acidic. So we were leaning towards a probable pneumonia that he might have either developed here or was it evolving during the process. So we continued on the meropenem, but this is when we also noticed that the patient had a recording. Possibly better. So this is where we had the rash. The one on the left side shows that the pink rash on the left hemithorax. trunk. And this is the one we have. I'm sorry. That was not recording. We had the salmon pink blanching rash on the trunk. Sorry. And this is during the tap. Over the next day, this is where the breathlessness worsened. The echo also showed a pericardial effusion. And we had called our respiratory medicine, and we were worried about if the patient was going into a macrophage activation syndrome, but there was no cytopenia yet, but the high ferritin levels were leaning towards it. So this is where we started the anti-inflammatory treatment. So we had given 1 dose of naproxen already in the morning, but since the effusion worsened, he required 2 liters of oxygen for the breathlessness. We had started right away on hydrocortisone, 1 milligram of prednisolone. And this was a repeat X-ray on 28th, which showed resolving serositis. And post initiation of the steroids, the fevers stopped completely. So CRP also dropped back to reduced to 36. And this was our treatment, 1 milligrams of prednisolone, and the dramatic improvement of resistant fevers and certain oral steroids. So the Stills, so it's a Stills disease, a rare disease. It's got a bimodal presentation, 15 to 25 and 36 to 46. And the basic mechanism is there's an innate immune cell activation, which triggers off this cytokine cascade. And the incidence is very rare. It's in the males, it's around 0.22 and 0.34 based on these Japanese studies, and the prevalence is also very rare, less generally. So it is in overall a rare disease, but so this is the classification criteria we use for Stills. There are 4 major and 5 minor criteria. Fever for more than or equal to 1 or 2.2, and for at least 1 week, and arthralgias for more than or equal to 2 weeks, so salmon rash or leukocytosis with neutrophilic predominance. And minor criteria is includes the sore throat, lymphadenopathy, hepatosplenomegaly, and abnormal LFT and LDH, and ANA and RF being negative. So 5 of this should be satisfied, with 2 of them being major criteria. So, and in our patient, we had 5 satisfied over the course. So the lab investigations usual picture is the elevated inflammatory markers with the leukocytes with 80% neutrophilia and low albumin and a high ferritin and high thrombocytosis, which is also inflammatory AP response, and negative ANA and RF. The salmon rash. So this is a evanescent rash, which is salmon colored maculopapular, which is non-pruritic and appears with the fever and classically resolves with the fever. It's seen more on the trunk and extremities, more, but sometimes can be seen on the palm, sole, and face, but classically on the trunk and extremities. So the take-home points were it is a rare disease, Yamaguchi classification criteria, and classic salmon rash as we described above, and young AUFA with no evidence of infection, but persistent inflammation still, although it's a rare entity, is a possibility.
Thank you, Daniel. I think that was a nice presentation, and I think you had taken a detailed history, and it was interesting to see the salmon rashes. Which again, did your patient have fever when the patient had a rash? That's something I wanted to ask you.
He had continuous fevers in the
and it
ward,
disappeared with the rash.
Yes.
The rash disappeared with the fever, is it?
Yes, sir. The next day we followed up, it faded half, 50%.
Okay. So usually, as in the cases that I have seen, they usually come with the fever and they go with the fever. Yes, so those are the ones that I have seen, but yeah. Any questions? Was this patient vaccinated for diphtheria?
Diphtheria. Historically, no, sir, we are not sure of the antenatal vaccination, but we did not find a membrane at presentation.
Did you consider that as a diagnosis, as a differential diagnosis?
For this,
some oral lesions.
Yes, sir. So we had a clear-cut candidal plaques which are scrapable on the buccal mucosa only, sir, not on the posterior pharyngeal wall.
Okay.
Posterior pharyngeal was clear when he presented, fully congested, red and erythematous, but the candidal plaque lesions were only on the right and left labial mucosa. Gingivo.
Because diphtheria can be a close differential for this. They got an oral lesion and they got myocarditis and settles with steroids. Could be a possibility, because Stills is something which is diagnosed of exclusion. What are this patient's alphas?
Alkaline phosphatase. Yes. It was 120, 40. 120.
Yeah, I mean, I wouldn't, I mean, Stills is something which is a diagnosis of exclusion.
Yes, sir.
I would probably rule out all the other differentials before labeling it as Stills.
Yes, sir.
No, I just little confused because this patient was already diagnosed of a juvenile idiopathic arthritis, no?
He was diagnosed with systemic JIA in 2013, sir.
In 20?
2013, sir.
How old is the patient?
He's 19 years old.
19. Okay. Who diagnosed that?
The pediatric, he was admitted under child health for the.
Okay. So, what is your opinion about systemic onset juvenile idiopathic arthritis and Still's disease? Are they the same disease, different diseases?
Their latest classification puts them as the same disease. There is no pediatric or adult version, but rather just Still's disease as one entity, which is pediatric presentation, adult presentation.
Sure.
It is part of the same.
So this patient was not under follow-up, is it?
He was not under follow-ups.
What did he receive in 2013 for the?
Sir, he had received naproxen at that time, sir.
Only naproxen.
Naproxen 125 milligrams as written in the discharge summary, but he had not followed up after that in pediatric rheumatology.
What is the basis of diagnosis then?
What is the base of diagnosis of the SJIA, sir? They kind of excluded everything else, and he was done extensive evaluations done here, sir.
Okay, it was a clear-cut diagnosis,
including bone marrow. They had done at that point also.
So that is why you thought that Still's is, like a relapse of Still's is a likely possibility because he has already been diagnosed. Is that right?
Yes, sir.
I'm trying to help you here and defend you against Dr. Karthik's question.
Yes, sir. Yes, sir. We thought it
because
was
this patient you wouldn't say
for a while and then it's come back again because.
Okay. Because you wouldn't say Still's as a first diagnosis, I mean, you wouldn't consider that without ruling out everything else, no?
Oh, right away from the get-go.
Okay.
Because the throat pain was very severe that we thought that could be an intercurrent illness apart from the whole thing.
That's fine. Now I'm saying that is what you should be thinking.
Yes, sir.
Yeah.
Any other questions? Okay. Thank you, Daniel. With this, we come to the end of today's clinical meeting. And I think for the best presentation of the day, for a very well approached case, I'm going to give it to Daniel. With this, we'll conclude today's clinical meeting. Thank you.